Hi, my name is Tess DeWulf and I'm a student nurse at Glacier Hills Senior Living Community. Today I'm going to present to you a patient who I had the pleasure to assess and interview. My patient has the initial CA and is a 61-year-old married Caucasian female. Her usual occupation is a facilities manager for humanities and social sciences at the University of Michigan, and her present occupation is the same, although she hasn't been able to work since she broke her ankle. Her usual source of medical care is Dr. Breton Schlosser. Patient's vital signs are stable with a blood pressure of 125/80, oxygen at 98%, temperature at 38.6 degrees Celsius taken orally, a heart rate of 60 beats per minute, and a respiratory rate of 15 breaths per minute. Her most recent immunizations include the flu shot administered in September and a TB shot administered when she was admitted to Glacier Hills on March 4th. Patient's chief complaint is pain in the left broken ankle and inability to walk. CA is a pleasant and alert 61-year-old white female who recently underwent a back surgery in early January. She broke her left ankle on Wednesday, February 25th. She was in her house when her legs gave out and she stumbled to the floor. Patient reports starting to fall in October and has fallen at least 24 times since then, causing more than one sprained ankle. The patient states that she believes she has a neuromuscular condition yet to be determined that it causes her to fall. She used a walker until she had an MRI that Friday on February 27th for her spine, but requested that they specifically look at her ankle, having not been able to bear weight on it the previous 2 days. The MRI showed mild displaced fractures involving the medial and lateral malleolus, with subtle mild displaced fractures involving the posterior malleolus at the level of the distal tibia. The on-call physician recommended that she go to the emergency room. Patient reports no pain in ankle even at the time of injury, unless she inverts it. Patient is unable to return home because her bathroom isn't wheelchair accessible, and using the walker is difficult because of the numbness occurring in her right leg related to her decompressive hemilaminectomy surgery. She hasn't been able to put weight on her ankle for the last 3 weeks. Patient received a boot yesterday and will most likely have to use a wheelchair long-term. She's been doing physical therapy, mainly focused on ESEM to the left ankle. Patient's health history includes chickenpox and measles when she was a child, and she had appendicitis when she was 14 years old. Patient has a history of anxiety, heaviness in both legs for the last 2 years, unsteadiness, not dizziness, for the last 2 years, Raynaud's since 1977, restless leg syndrome for the last 5 years, but it has gotten much worse since her spinal surgery, hyperhidrosis since childhood, hypertension for the last 15 years, and seborrheic dermatitis for the last 2 years. Patient has also had irritable bowel syndrome, osteoarthritis, dyslipidemia, heavy drinking, and spinal stenosis. The patient reports no allergies except for a systemic allergic reaction she had to Monistat 7 12 years ago. Patient reports having to seek emergency care after a rash spread over the entirety of her body and her ears closed up. Patient's past hospitalizations include a left knee replacement in 2011, a right knee replacement in 2013, an appendectomy in 1968, and a recent lumbar spine surgery on January 6th. Patient is on 20 milligrams daily of simvastatin to lower her cholesterol, 20 milligrams daily of Lexapro for anxiety, 100 milligrams daily of losartan for high blood pressure, and 0.5 milligrams to 2.5 milligrams at night of ropinirole for restless leg syndrome. Patient reports use of tobacco, but quit in December for her hip surgery. She used to smoke a half a pack a day. Patient used to drink every day, but hasn't had a drink in 2 months. She reported drinking 2 or 3 drinks when she returned home from work every night. Patient denies any illicit drug use. She feels that she was a very healthy woman before surgery, was a frequent tennis player, swimmer, and did aerobics and walked every day. Patient reports getting approximately 7 or 8 hours of sleep a night. She doesn't drink coffee, but drinks tea frequently. The patient has 2 sons, ages 30 and 29, that she has solid relationships with. Both live in the area and she sees them often. She has a grandson that is 3 years old, and she tries to have dinner with her family once a week. Patient reports no stressors in her life, although she reports having frequent hypertension, and that causes her to be slightly anxious. Patient is an elder and deacon at her local Presbyterian church. Through all of her health issues, the patient has a supportive husband and family and states that she feels she is in good hands. Patient reports that her dad died of congestive heart failure, and her mom is currently 93 and is in very good health. She has one brother and he is still alive, and patient states that he has no medical issues. Due to the patient's ankle injury, spinal surgery, knee replacements, and right leg numbness, it is important to assess and be aware of the patient's mobility and strength and assess the musculoskeletal system. Patient states that there's very minimal pain in her body except in the ankle when she inverts it. Patient has weakness, numbness in both legs, but especially the right one. The left one currently has a boot. Patient reports a history of osteoarthritis, but joints are not warm, deformed, red, or swelled. There is no pain in her joints, but there is weakness present. Recent surgeries have caused major difficulty in ADLs. Before being admitted, patient had to use a walker due to leg weakness. Now, patient can take 3 to 4 steps with the walker. She is able to stand independently and can get in and out of bed okay. Patient has good sitting and standing balance. She can go to the bathroom without assistance, needs moderate assistance for bathing, and set up for dressing and grooming. Range of motion is difficult in lower limbs due to muscle weakness, but upper extremities are normal. Upon physical assessment, patient has normal and even bilateral muscle mass. Her posture is upright and steady. Patient was unable to exhibit gait because of new boot and unavailable walker. Patient tested negative for scoliosis. There is no arrhythmia, inflammation, pain, warmth, or crepitus while palpating TMJ, neck, shoulders, elbows, wrists, fingers, hips, knees, ankles, or spine, except some edema present in the left ankle and knee joint, and pain present in the ankle when inverted. Range of motion is within functional limits in all joints except there was some hesitation and uneasiness viewed in the range of motion on the lower extremities due to muscle weakness and numbness, including adduction and abduction of the hip and flexion of the right knee. I was unable to assess range of motion of the knee and ankle on the left side of the body due to the boot. Muscle strength of the deltoids, biceps, triceps, and wrists were all 5s on the muscle strength scale. The right hip was a 4 and the left hip was a 5. I wasn't able to assess strength on the left hamstrings, quads, and ankle. Those same muscles on the right side of the body were all a strength of 4, and patient notes paresthesias prominent on right side of body, especially in lower extremities. It was difficult to decide on the next system, being that the patient has health problems in several different systems. However, due to the patient's hyperhidrosis and seborrheic dermatitis, I decided to assess the integumentary system. Patient reports that when she was an active tennis player and walker, she spent a good amount of time outside and in the sun, but she would take necessary precautions such as wearing a hat and putting on SPF 50 sunscreen. Patient has noticed no changes in hair, nails, or skin. She has extreme dryness and itchiness in ears due to seborrheic dermatitis, which started a few years ago. Patient reports no rashes or itching. She reports excessive sweating or hyperhidrosis, especially present on the hands and feet. This condition has been present since birth. Upon physical assessment, there was no flaking or lesions present on the scalp. Patient has strawberry blonde hair that is beginning to gray. The hair is soft and thin and normally distributed on head. Skin is clean and there is no body odor present. She has excessive sweating present on hands and feet, but especially on her hands. Patient has fair skin with no presence of arrhythmia. Patient has freckles and moles present on face and arms with no other prominent skin landmarks. She has normal skin thickness, smooth texture, and little or no moisture except on hands and feet. Patient has identical lateral scars present on both knees due to knee replacements. She has warm and very dry skin with edema present on the left lower extremity where a broken ankle is. Itchiness and flakiness of the skin was present in both ears. Mobility is within normal range and turgor tested on the anterior side of hand returned back to normal position in less than a second. Nails are clean, pink, long, and normal shape, contour, and thickness. Capillary refill is 1 second. My first pertinent system would be the neurological system. I would have chosen to do this system as one of my assessments, but we haven't yet learned it in class. I would choose a system because my patient's legs have been randomly giving out for the past few months. She has paresthesia in her lower extremities, and even when she broke her ankle, she didn't feel any immediate pain. The patient also has spinal stenosis, which is narrowing of the spaces in the spine, which can cause pressure on the spinal cord and nerves. This could explain the reason why her legs have been giving out and feeling numb. According to a study conducted by the Journal of Rheumatology, it is important to assess the neurological system, including cranial nerves, because medical researchers found that patients with lumbar spinal stenosis have lower weakness of the lower extremity as measured at rest. Subjects were also seen to have impaired vibratory sensation and reflexes, especially shown in the lower extremities. The brain has an important relationship with the muscular system, and especially in my patient's case, it is important to perform a neurological assessment. The second pertinent system I would assess would be the cardiovascular system. I feel that the system is important to assess because my patient has a history of hypertension, anxiety, alcohol and tobacco use, and her father's death caused by congestive heart failure. According to a research article written by Dr. Kenneth Mukamal for the National Institute on Alcohol Abuse and Alcoholism, it is important to assess the cardiovascular system because the combination of smoking and drinking on the human body causes major cardiovascular issues. If one drinks 3 or more drinks per day, he or she clearly increases the risk of stroke and myocardial infarction and also raises blood pressure, as seen in the hypertension of my patient. If one drinks and smokes, their risk of congestive heart failure significantly increases. In both cases, smoking and drinking can affect the viscosity of the blood. In the case of excessive drinking, blood can thin in the patient. In terms of excessive smoking, patient is at significant risk for developing a blood clot. In conclusion, with my patient's family history of cardiac health problems, her past tobacco and alcohol overuse, and her hypertension, assessing her cardiovascular system is very important.